This is a 7-year-old male patient presented with pain after a 1 month history of trauma.
Okay,
Go on.
so I'm presented with this plain radiograph of the left leg, tibia, and fibula, with partially included knee and ankle joints. And a child has presented with a 1 month history of pain after trauma. So here I can appreciate that there is marked abnormality within the tibia, predominantly involving its majority of its shaft, and there is also some surrounding soft tissue swelling. There is loss of the normal cortex and medullary differentiation, especially along the medial cortex, and these changes appear chronic. The There is some lucency and sclerosis throughout the shaft on the medial aspect, as well as cortical irregularity. At the same time, I can see that there is some irregular lucent trach at mid shaft, which is extending towards the medullary cavity. And there is also some lucency or bone loss in the cortex as well. So I'm thinking of the line of some chronic infection superadded on this trauma. So I will, in my routine practice, I will also check the lateral view. Yeah, so in this view, again, I see that there is cortical destruction, especially the medial and posterior aspect, with lucency and sclerosis throughout the majority of the tibial shaft, and there is marked soft tissue swelling and some hyperdense focus posteriorly within the projected over the calf muscles. So I'm thinking of the line of post-traumatic infection with osteomyelitis and sinus tract formation. So in my routine practice, I will discuss these findings with the referring clinician with to look for any discharging sinus or trach, any recent ultrasound images. If not available, I will further evaluate it with an MRI to delineate the details. So I presented with this MRI images. Uh, am I scrolling, sir, or you are scrolling for me?
Yeah, you can scroll. Go on.
Yeah, I'm trying. Mm, it's a bit lagging. So I can, the MR images confirm my finding of abnormality within the tibia, especially the medial cortex, which appears more dark and thickened and irregular with a high signal fluid tract extending medially, laterally from the medial aspect into the tibial shaft with marked edema throughout the medullary cavity. There is also periosteal elevation and high signal along the medial aspect and some marks of tissue swelling. So in my routine practice, I will also check the T1 pain post-contrast images for any collection or enhancement pattern.
Unfortunately, we don't have post contrasts.
Mhm. So I will also check the DWIDC for any restriction of diffusion. Uh, in these images, because there is marked edema in the soft tissues,
What's
uh,
your first differential diagnosis?
so it's post-traumatic osteomyelitis, chronic osteomyelitis,
What else?
possibly discharging
What else?
sinus. The other possibility could be if this patient has a known prior pre-trauma, uh, some chronic osseous process. So I'm also thinking of the lineup eosinophilic granuloma and chronic recurrent multifocal osteomyelitis as well in the consideration.
Okay. Could you have any pathognomonic sign here for any of those differential diagnoses?
Mm, I'm
Look
looking for,
here.
yeah, so, yes, so because there is a cloaca formation, the tract
Yes.
formation, extending from the medullary cavity into the soft tissue, medially and posteriorly. So this favors the diagnosis of osteomyelitis rather than eosinophilic granuloma and CRMO.
What's your next step, please?
So I will inform these findings to the referring clinician and would advise like any if there is a pus discharge with any culture and at the same
What
time
else? Okay. What
and
else?
also discuss with the pedic because this patient needs like surgical management
Why surgical management?
because it's like
Somebody suggested to give antibiotic and wait.
Mhm. Yeah, but
Some. Hmm.
yes, both options will be discussed like with regard to conservative management as well as
What
surgical
do you
management.
prefer according radiological finding? What do you prefer and why?
There is a low signal focus within this cortical region of the trach. So I believe this is a sequestrum, and
Excellent.
it needs to be removed because it will be a constant source of infection.
Which type of infection?
Uh, in terms of like organism or
Okay, don't worry. Thank you so much, doctor.
thank you, thank you.
You did very well here, but you take not too much time. In my opinion, this from the frontal is more than enough.
Yeah,
This is post-trauma,
yeah,
ill-defined, wide zone of transition,
yeah.
lytic sclerotic lesion involved all the tibia with periosteal reaction, cortical defect. So this is aggressive, associated with soft tissue thickening or edema,
Mm-hmm.
and you must save the time as much as possible.
Okay.
So you will, it is better in pathognomonic or very obvious lesion like this. Don't waste the time. Don't ask for other play. You may tell the patient, okay, the examiner, I will also have a look to the other plane to confer.
Okay.
This is a point. Okay. Next point, I'm trying to help you to
Mm-hmm.
listen from you one word. This is chronic or acute osteomyelitis. I ask
Mm-hmm.
you many questions,
Mm-hmm.
many questions.
Mm-hmm.
Which type of osteomyelitis have a cloaca, have a sequestrum, has involucrum? Only one type, chronic
Exactly.
osteomyelitis. Why we should, my colleagues, make a definite diagnosis of chronic or acute? Acute, the management is mainly conservative antibiotic like this, except if there are Brody abscess. Okay, but chronic osteomyelitis surgical. It must, this patient must undergo surgical debridement. See, this separated dark fragment is the sequestrum. This is the
Ex-
cloaca. And look here, look here, my colleagues. This is thickening of the cortex. This is the involucrum. Involucrum is yeah, thickening of the cortex, a process of separation between healthy and the necrotic tissues. Okay, so it is very important to tell the examiner is chronic or acute. Why? Because the management is totally different. Thank you, doctor. You did very well, but this notes for your benefits. Next
ex-
candidate,
Thank you.
welcome.
Hello, sir.
Welcome. Hello. Last
Hello,
candidate,
sir.
leave
Good
the
evening.
mouse. Hello. Good evening. Last candidate, leave the mouse, please.
Silent.
Leave.
Okay.
1 second. Doctor, this is
Hello.
20-year-old, yes, 20-year-old male patient presented with um, acute trauma and inability to extend the knee. Go
Okay.
on.
S- So I'm presented with frontal radiograph of me of a 20-year-old patient. I can appreciate there is an ill-defined, lucent permeative lesion in the lower end of metadiaphyseal region of femur, which is having a wide zone of transition. There is
Mm,
cortical breach along with
mhm,
thin periosteal reactions, giving
yes.
the appearance of cord band strangle. There is also
Mhm,
soft tissue swelling noted in the left medial aspect of the lower end of femur. So, in my routine practice, I would also check with the other orthogonal views, and the appearances are keeping in okay, yes, the lateral. Yes, in the lateral view also reconfirms the diagnosis. There is also periosteal reaction, sunburst, and making a cord band strangle. My diagnosis would be osteosarcoma, and I would also like to confirm my diagnosis with MRI. Arranging MRI, I would urgently inform the referring clinician, send the patient to sarcoma center. Okay, so I'm presented with MRI of left femur. I can
request
appreciate
control,
there is.
please. Request control.
Okay. Yes, sir, please. Okay.
In some cases, you must scroll to get the maximum benefit of the hot seat here. Go on, scroll.
Very slow, sir.
1 second. 1 second. I will help you. 1 second. 1 second. Leave the mouse. Leave.
Yes.
Use the arrow. Use the arrow,
Yes.
please.
So I can see there is an undefined lobulated lesion
Yes.
noted in the metadiaphyseal region of femur, lower femur. There is
Mm.
uh, now the zone of transition appears to be narrow though, and there
Why
is
you
soft
didn't
tissue.
scroll, doctor? Doctor, scroll.
Sir, I'm trying.
Okay, I will help you.
Okay,
Okay.
sir, am I scrolling now? Is it
Yes, you are
normal?
scrolling now.
Okay,
Go on.
okay, okay. Okay. So, yes, there is a faint hypo intense line surrounding it, and the lesion is breaking the cortex, and yes, it is extend to the soft tissue.
Mhm.
So my differential would be yes, it can be osteomyelitis. Will come to the differential along with
Mhm.
osteosarcoma. There is periosteal reaction.
Mhm.
So I would like to correlate with the history and send the patient to for biopsy. My diagnosis would be osteosarcoma and differential would be osteomyelitis.
Okay. What else? How can you differentiate? How
There
can you
is
differentiate, doctor?
uh, we can take biopsy from the lesion.
Okay, I'm asking you from this exam, from this MRI, and see, give me more description, doctor.
Uh,
يعني I recommend many times don't take too much time and don't jump immediately to the diagnosis. Try to
okay.
be middle descriptive style.
So this is a fat saturated contrast enhanced MRI, and I can appreciate there is an ill-defined lobulated lesion in the
Yes,
metadiaphyseal region of femur, which is
yes.
breaking the cortex, breaching the cortex, and it
Mm-hmm,
is extending to the soft tissue. There is
mm-hmm.
surrounding edema and
Yes.
a hypo intense surrounding uh, line. Yes. Okay.
What happened here?
You're having a lobulated, yes, lobulated intense. There are multiple, yeah, blood, fluid levels inside.
Okay.
I can appreciate few fluid levels inside.
Yes.
So yes, so my differential, the differential can be, uh, but it is, but it is extending outside.
Okay, so
It's telangiectatic osteosarcoma.
how can you differentiate? Give me differential diagnosis first for this sign, fluid level.
It could be AB, aneurysmal bone cyst, but it wouldn't
Okay,
reach the
or
cortex and come outside. Or
so you are worried about
I'm worried about breaching of cortex and periosteal reaction.
how could you differentiate between ABC, aneurysmal bone cyst, and osteosarcoma?
Aneurysmal bone cyst would be in the metadiaphyseal region.
Okay,
It would be a well-defined fluid level uh, blood-filled level
what else?
lesion.
What else? Only one differential point is very important.
It wouldn't breach the
Very important.
cortex. It is
What else?
expansile. It is
What else?
expansile. It is in
What else? One very important point, very important.
periosteal reaction.
Differentiate.
It would not be present in
Okay,
ABC.
what else? I will help you, but it will not happen in the exam. Hmm. Think, 10-second chance. How could you differentiate between at least primary or secondary aneurysmal bone cyst? What is the difference between both of them?
Sir, I don't remember then.
Look here. If I told you, what is this? Yes, this one. Look here, please. Could you think this is post contrast or pre contrast?
This is this is
Hmm?
clear image. Fat saturated pre-contrast.
No, this is post contrast. Look to the vessels. Look, look.
Okay.
Okay, this is post contrast. Step by step, what you are searching for to differentiate between a primary pure aneurysmal bone cyst and the others. Hmm. Did you find anything? What is this?
This is
Can you see my
edema.
arrow? No,
Yes.
this is uh, now this is post contrast. Post contrast.
Okay.
So what is this?
This is a blood-filled lesion. I mean,
Doctor, this is post contrast. So this is something that take contrast, something enhance it. So look, what
okay.
is this? What is this nodular enhancement? Hmm.
This
Soft
is a
tissue.
soft tissue. Yes, this is a soft tissue part.
Yes, soft tissue.
Uh-huh.
Okay, excellent.
Soft tissue part.
So what's your final diagnosis?
So it is telangiectatic osteosarcoma.
Excellent. What is your next step?
I would refer the patient to the sarcoma center for biopsy
Mm-hmm.
and then
Yes.
suggest CT scan chest abdomen for staging and metastatic uh, changes to look for metastasis, search for metastasis. And
Thank you so much, doctor. See my colleagues here, please. All cases that I bring in sessions have a learning point. You did very well in the X-ray. You tell everything. This is L-defined, wide zone of transition, permeative or moss-eaten lesion, whatever, with periosteal reaction. And in the lateral, I think there are some cortical bridge. This is aggressive lesion. Like this, you smashed the X-ray. If you told the examiner, my first diagnosis, differential diagnosis is osteosarcoma, he will be very happy. Doctor, I want you to do post-contrast MRI. Post-contrast MRI. What happened here? Very confusing. Why? Expansile. Very expansile lesion, but with cortical break fracture and extra osseous extension. Okay?
yes,
It may be a maybe fracture within the aneurysmal bone cyst. but at least we are in the pathway of malignancy. So I should ask the examiner for post-contrast. Why post-contrast? I should pick up any soft tissue. The soft tissue
Okay.
here is the key. The soft tissue is the key. Look here. Look here, my colleague. What happened here? This is periosteal reaction. But this lobulated heart or triangular shape mass. This is the soft tissue mass. Okay? And even here, look here. Look. All of this enhanced mass lesion, enhanced nodular enhancement. Overall, my colleague, we divide aneurysmal bone cyst either primary, which is a pure non-malignant, or secondary. Secondary aneurysmal bone cyst may be associated on top of pre-existing tumor with cystic changes upon it, like fibrosarcoma, whatever. Okay, even fibrous dysplasia may have some cystic changes and have يعني upon it aneurysmal bone cyst. But the most important to rule out telangiectatic osteosarcoma. Why? Because the patient is 20-year-old. Very important. Very, very important. Two different ways. Okay, my colleague, how we differentiate by the solid, yeah, the most important, by the solid component. Very, very important. Okay. Thank you, doctor, so
Okay, sir.
much.
So the
Extended
diagnosis is telangiectatic osteosarcoma,
telangiectatic.
the
Sure,
final view.
sure. Look,
Yeah. Okay.
telangiectatic
Okay.
osteosarcoma. Okay,
Okay.
thank you so much.
Thank you, sir.
Leave the mouse, leave, please. Leave the mouse. I think this is, yeah, this is the follow-up. Look, my colleagues. See, my colleagues, this is, I think, after a longer follow-up. I don't know why the patient wait all of this, but look here. The soft tissue enhanced soft tissue component is more larger. Somebody will ask me, doctor, why didn't you show us this case? Because this is very obvious. You will not mistake this one. See, very prominent, large, solid component, enhanced solid component. But in Viva, they like to bring the early stages, the subtle finding like this. Okay, my colleagues, sure you might see the patient underwent some amputation or limb salvage. This is called this operation limb salvage. They save the limb. They remove only the affected part. Before, in the old ages, this patient must underwent above knee amputation. But now, thanks to the new technology, they remove only the affected part and preserve the rest of the limb. But the patient must undergo regular follow-up. I saw before one patient like this come to my center and do one MRI. There are new techniques in MRI that can deal with this metal artifact. This techniques called, especially in GE machines, very good. I didn't remember the whole name because it is a sophisticated name, but um, something like metal artifact reduction technique like this. Okay, my colleague, very important now, the limb salvage surgery. Next candidate.
Hello.
Hello,
Hello.
welcome.
Yep.
Welcome.
Hello, doctor.
Doctor, yeah. Doctor, this is 45-year-old male patient with a road traffic accident presented with shoulder pain and restricted movement.
Okay, I've been presented with a 45-year-old male with shoulder pain and restricted movement. Been provided the coronal stir images, fluid sensitive images. I can see that there is altered signal intensity, which is seen in the joint capsule inferiorly. I would okay, I can see a few rounded hypointense areas within, and
Mhm.
I um, can also see some distension of the joint capsule as well at this region. There's some minimal joint effusion, and I would can also see that there is um, edema seen posteriorly in the humeral head. Can I also see the glenoid um, margins as well, if possible?
Mhm. What else?
Um, I can also see uh, some edema in the humeral head in the posterior aspect, and um, trying to look at the glenoid to see if there's any anterior. Yes, I can see anteriorly. I can see that there is a hypointense line going along the anterior superior aspect of the
Mhm.
glenoid. Like to look at any this disruption of the um, ligament of the cartilage as well. Um,
Mhm.
okay, I can see anteriorly. Yes, I can see that there is a disrupted fragment from the glenoid. So this is likely suggesting Hill sacks and deformity of the humerus with an associated um, bony bank cut. And I would inform my findings to the referring physician and also the orthopedic surgeon as well for management for this patient.
So what's your final diagnosis, doctor?
This is um, uh, recurrent anterior dislocation with bony bank
Where is the bony Bankert?
lesion.
Where is the bony Bankert?
I think anteriorly I can see. I think um,
Where?
here. Okay.
Where is the bony Bankert?
Oh, okay. So it's not bony. Sorry, it is not bony bank cut. It's just because of the um, defect in the glenoid labrum. It's not a bony bank cut. I thought I was seeing the bony lesion on,
Yes,
but I would
doctor,
like to.
doctor,
Yeah.
doctor. Conclude the finding. What's your diagnosis? Give me a radiological buzzword or diagnosis. Okay. Where is the Bankert?
Um,
Where?
anteros anteroinferiorly.
Okay. So what's your final diagnosis?
Um, my final diagnosis would be um, injury to the glenoid labrum,
Mm-hmm.
and so this would be reverse Hill sacks with reverse
Where is the
Bankart.
reverse
Sorry.
sac? Yeah.
Uh,
Yeah.
yeah.
Yeah. Where is the
So
reverse sac? Anterior or posterior?
anteriorly.
Okay. So where is the Bankert?
So the
Anterior
Bankart will
or
be
posterior?
posteriorly.
Sure. Okay.
Yeah.
Okay, I'm about to finish this case يعني without a proper answer from you. Okay, so this is okay. What happened anteriorly? You consume most of the time anteriorly, despite the disaster is posteriorly. What happened anteriorly, doctor? What is this?
Anterior.
You are describing in this. What is this?
Yes. That
What is
is
this?
the um, glenohumeral ligament.
Yes, it looks like hypertrophied. So you mistake it as a valsate leg, fragment or something like
Fragment.
this.
Yeah.
Okay. What's your next step, doctor?
I would inform my findings to the referring physician and also the orthopedic surgeon so that the patient
Mhm.
would have surgical management.
Okay, thank you, doctor, so much. My colleague, see, if each case you will be presented with in the exam, short, long, Viva, each case has one key. Okay, even in our practice, each case has one key. When you catch this key, you catch the correct step, first step. What happened here? The patient is trauma, and what happened? I give him at the beginning this one. Why? This is the difficult one. Okay, but the most important finding here, this one. There are something here or here. So there are upper humerus, including the head, edema, and the looks like fracture. Doctor, please give me the axial. This is after you at least told him the supraspinatus syndrome is intact, superior glenoid, this one, and the biceps. This is the biceps. See my colleague, biceps, insertion in the superior glenoid and the superior labrum. At least this intact. You show has seen some finding here. Okay, tell him there are the inferior recess. At least it is strained, and I have a suspicion there are tear here, but it is connected still. Maybe he have some tear here, but all of this is not the major finding that the examiner want from you. You must examine the axial to solve the puzzle. When I give the axial, look here, as long as you are not below the coracoid, where is the coracoid? This coracoid, okay? Okay? Still the tip of coracoid here. Anyway, this is not acceptable. There are some defect here. So your doubt must go through the reverse banker. So you must look here. There are very clear torn of the posterior labrum. So this is a reversed Bankert. Sorry, this is a reversed Bankert with reversed health sac. At least if you forget all these names, tell the examiner there are posterior lateral complete tear plus impaction fracture here, which is a reversed health sac. What is this? I don't know really. It is confusing. Go directly to the subscapularis tendon. Go. If this structure lying down upon it, this is the middle glenohumeral ligament. See this one. This is the middle glenohumeral. Okay. If you follow it, see, you will catch the glenoid here at the same insertion of the superior glenohumeral ligament. Okay, my colleague. What happened here? Maybe some contusion, degeneration, whatever, but still the anterior labrum almost still not bad. The striking abnormality is in the posterior. And the rest of the finding like contusion here or fluid around the biceps, all of this side finding. Okay, my colleagues, what is the diagnosis here? Reversed LSAC with a reversed pancreas. Even if you forget the names, but you tell the exact anatomical location, injury, and the injury, I think you will pass. Okay. Thank you, doctor, so
Thank you.
much. Next,
Thank you, doctor.
thank you. You did very well, but this is the problem and the difficulty of the MSK injury. Okay,
Yes, doctor.
mute
Thank you.
yourself, please. Uh, what happened in the MSK, especially post trauma? Too much site finding, especially edema, confuse you so much. So my advice to you, try to put your hand from the beginning, add the most striking finding and start from it. Thank you so much. Next candidate.
Assalamu alaikum.
Wassalam. Doctor, this is 50-year-old male patient presented with intermittent bilateral anterior knee pain worsening with ambulation and improve with rest. Mm, Go on.
Okay, I'm presented with the
Request control, please.
sorry, cannot request control as
Okay,
I'm
okay,
on touchpad. Can you please? Okay.
okay.
So I'm presented with the MRI sagittal PD fat saturated images of the knee joint, in which I can see that there is no evidence of any marrow edema or contusions. The menisci appears unremarkable. Their anterior cruciate and posterior cruciate ligaments show no abnormality. The
Mhm.
popliteal tendon show no abnormality.
What is your next step? The patient has
I would like
complaints. Mhm.
I would like to see rest of the images like the axial and coronal images. In these images, I cannot see any evidence of contusions. I'm looking at the neurovascular bundle. There is normal enhancement of the popliteal artery. There is some muscle between the two vessels, which is causing mild compression of the vessels anteriorly, likely
Okay,
pulmonary the popliteal artery,
okay.
and causing separation of the two vessels. I would correlate with the MRI of the other knee to compare and correlate with the opposite knee. Mm,
This is MRI of the other knee.
Okay, so and the other knee MRI, I can see the same abnormality as seen in the prior MRI.
So
So it could be.
what's your diagnosis?
So I'm suspecting bilateral popliteal artery entrapment syndrome.
How could you
I
confirm it?
would.
How could you
Mm,
confirm it?
I can confirm it by us correlating with the patient's history of any cyclical claudication, which increase with the exercise and decrease with the resting. And we can also perform a dynamic MRI, in which we can with flexion and extension and compression on the popliteal artery during movement.
Could you have something يعني more simple than dynamic MRI?
Doppler ultrasound, we can do a Doppler ultrasound.
Okay. What will happen?
In Doppler ultrasound, while movement of the flexion extension of the leg will cause compression of the popliteal artery and with reduction of flow in the distal branches of the popliteal artery, including the posterior tibial and anterior tibial arteries.
Doctor, thank you so much. Really, it was the case of today. What happened, my colleague? Thank you, Doctor, really so much. After you, if you examine one sequence like this or like this, and you didn't find really any obvious finding, the examiner may not give you anything else without your asking. You must request. He requests this one. All of us start from, or either this, start from the ligament bone like this. And this is very good, by the way. If we didn't find anything, go to your review areas. One of the most common, I will give you at least now four review areas. One is the popliteal vessels. Normally, both are abutting each other. You mustn't see any muscles, ligament, anything here between of them. If you saw something like this, both popliteal artery entrapment syndrome until proof otherwise. Despite we did the other limb MRI, but it is bilateral. Okay, and it was the trick here. Somebody may tell this is a normal variant. No, this is not normal variant because the patient has symptoms. Number two, if you examine and there are nothing, look here where suprapatellar, here suprapatellar impingement syndrome. What will it show? Look, this bright fat here. Here in the suprapatellar impingement syndrome, you will not find the bright T1 fat. It will be edematous, so it will be low. And in the stereo, it will be high. This is second. Third, look at these muscles. You may have tear here or here, even without knowing the name. Don't confuse yourself. What is the name of this muscle? At least you will see, oh, this is tendon, this another tendon, like this. In any plane. Number three, and very important, number three or four. Number four, very important. Look to these ligaments. Is this intact or not? Very, very critical. Sometimes they give you a very normal, looks like normal MRI, and finally the finding is here, rupture of the quadriceps tendon. So at least this is a four very important and the common exam question in four review area of the knee. Thank you, doctor. Next candidate.
Yes. Yes.
And
Good evening.
are you ready?
Yes, please.
One second. Okay. Doctor, this 16-year-old male patient presented with left low back pain and left sciatica. You can start. He underwent skeletal survey. Go on.
Yes, please.
Go on.
Yes, I have presented with 16 years old boy with have for skeletal survey because of lower back pain and sciatica. The patient presented with multiple, I think, spondylodiaphyseal or uh, bone dysplasia in the vertebrae
Yes.
and right-sided scoliosis of the lower lumbar vertebral body.
Mhm.
He also has the premature closure of the physis.
Mhm.
He has the fifth metacarpal bone smaller and first metacarpal bone smaller than other metacarpal bones, and he has a slightly sclerotic density of the bone. Maybe this has a blunt disease because of medial deviation of the distal epiphysis and the metaphysis of the distal radius and ulna.
Blonde disease.
Hmm?
What else? What else?
Uh,
What else?
Maybe this can be caused by spondyloepiphyseal dysplasia because of the vertebral bones also with the epiphysis that showing dysplasia because of the medial aspect of the distal radius that's showing uh, approximation of the carpal bones. And so I want to see what is there is a skull bone.
Is
There
a
is
skull?
also the skull showing that the skull base showing slightly sclerotic. like
Mhm.
sclerosis, and also the same finding. This is plate-like or disc-like uh, vertebral bones. So,
Mhm.
so the first possibility it will be spondyloepiphyseal dysplasia.
Okay. Versus which syndrome is common with Pilates spondylitis? Mm.
Mm.
You are correct, by the way, but I need another differential diagnosis.
Clever. Uh,
Mm. Okay. This is the MRI. What else?
Mucopolysaccharidosis, but I don't think this is
Okay. So we have two differential, mucopolysaccharidosis and
spondyloepiphyseal dysplasia.
spondyloepiphyseal dysplasia. How could you differentiate between of them from this? Mm.
Uh, central peaking of the vertebral bodies.
Yes. Excellent. There are any peaking here?
No.
So what's your final diagnosis?
Again, maybe spondyloepiphyseal dysplasia. I will discuss
Excellent.
the case with the pediatric and send for genetic consultation.
Excellent. This is the diagnosis, my colleague. Spondyloepiphyseal dysplasia. Thank you, doctor, so much. What happened here? Multiple level of reduced height of the vertebrae, which is called flat spondyloid. Multiple, without anterior peaking. And all the epiphysis has a problem here. Defective growth. Look here, look. All the epiphysis, even here, the femur. We have a problem here. So this is a problem, this case, a problem of epiphysis and spine. So combine the finding like a puzzle. You will get spondylo and epiphyseal dysplasia. Okay? What is our differential diagnosis? Our differential diagnosis exactly the marker or mucopolysaccharidosis. Exact finding, except in mucopolysaccharidosis, the skull must be large. Skull here, by the way, is normal. Hand here is normal. Okay? Despite you can feel that there are a little bit anterior pointing here, but this is normal. This is not a true. In mucopolysaccharidosis, you must see pointing of the metacarpal bones. Some pointing, some thinning in the ends of the metacarpal bone. So this is spondyloepiphyseal dysplasia. Why? Normal skull, no anterior peaking of the spine, okay? And the hand is normal, completely normal. If you give the examiner the two differential, they will be happy. Why? Because you pick up this is a syndromic patient. Syndromic patient need more and more investigation to be well diagnosed. This is not emergency. This is not tumoral. So you are running in the correct pathway. Thank you, doctor, so much. Next candidate. I think yes, thank you. Doctor?
Hello.
Yes. This is 30-year-old male patient presented with left knee pain after injury by the bicycles.
Okay. I'm requesting control.
Yeah, go on.
Okay. These are of MRI knee of a patient. Hello.
Yes, yes,
Uh,
I can hear you.
okay.
Go on.
Okay. In this, I can appreciate that there are multiple hypo involving the patella as well as the tibia on the T2 weighted image. and appreciate that the patellar retinaculum, and so is the iliotibial band, and there is some noted around the tibia, and there is I would also like to have a look at the images.
What?
Get the sagittal images if available.
This is these are this is the
Okay.
sagittal images. Go on.
Okay. These are the sagittal images of the MRI, sagittal PD weighted. I can first I'll have a scroll, then I'll start speaking. The anterior cruciate is normal. The fibers are in.
Hello? Hello? Hello?
Hello.
Yes, this is your voice, please.
Okay, sir, can I yeah, all these
Hello?
I'm hello.
Yes. Tell me, what's your diagnosis, doctor?
Okay, sir, if you can please kindly scroll it for me once.
Yes,
Okay,
yes.
I can appreciate that the posterior cruciate ligament is absolutely fine, and the anterior cruciate ligament shows some hyperintense signal within its substance. And however, the fibers are intact, and I can appreciate that there are multiple hypointensities noted within the metaphysis of all the visualized long bones, and also as well as the patella. And I would also like to look at the stir if possible.
Disaster. What happened?
Okay. Okay. On the star, I can appreciate that, sir, there is a tear of anterior cruciate ligament, and
What
there
else?
is.
Don't
Okay.
see. Don't worry about the ligaments.
Okay. Mm, okay. Sir, there is some joint effusion and. Mm,
Doctor, you find
yes.
a big finding here, and you didn't talk
Okay, sir,
anymore about that.
I'm thinking that maybe these are, is the patient has any history of leukemia or lymphoma, due to which these hypointense signals are noted within all the
What
visualized
else?
bones.
What else?
Other possibility could be, sir, kindly can you repeat the history of the patient?
I will not repeat the history. Give
Okay,
me a differential
okay,
diagnosis. Don't
okay,
ask the examiner in the middle to repeat. He
okay,
will demarcate you. You can ask him after in the beginning. He told you the history and you didn't listen. Well, doctor, please repeat. Okay, this is acceptable. In the middle, it is a
okay.
bad sign against you.
Okay,
Hmm.
okay, sir. Okay, the other possibility could be that these are, sir, contusions, but they should be higher on the stir.
Do
And
you want any help, doctor? Do you want to see any investigations?
mm,
This patient has a trauma. Before he come to MRI, he did something.
okay, mm,
The
yes,
patient come
sir, I
immediately to
would.
MRI, or should do some simple.
Yeah,
Uh,
sir, we should go for an X-ray also to look for any abnormality on that. And okay, on the X-ray, I can appreciate that there are multiple sclerotic foci noted within the metaphysis, and
what's
which
your
appeared,
diagnosis?
sir,
What's your
osteophylosis,
diagnosis?
osteophylosis, and these foci
Thank
were
you,
hypointense.
doctor.
Yes, sir.
Thank you.
Next, I
This
would
is very
like to correlate on the bone scan. These would be called on the bone scan. And
okay, but the most important, even you
yes,
find something here like this
yes,
and
sir.
you are confusing, ask for X-ray. I
Okay,
told
yes, sir.
you
Yes,
last
sir.
or last week, no any MRI joint without X-ray,
Yes,
even
sir.
in the
Yes, sir.
practice. Most
Okay,
of
sir.
patient underwent an X-ray before MRI. So
Yes,
ask
sir.
the examiner. If you told the examiner, doctor, this is multiple variable size, small, low dense, or low density, low intensity lesions in all sequences,
Yes, sir.
surrounded the heads, the epiphysis of knee joint.
Yes, sir.
Okay,
Yes, sir.
doctor, I'm worried about many differential diagnosis, but I wanted to have a look if, for all the X-ray.
Yes, sir.
Why? Why?
Okay.
I will tell you frankly, because when I saw uh, this MRI, I asked
Yes, sir.
myself, like you, what is
Yes,
this?
sir.
It may be leukemia. It may be, what is this? It looks like calcification.
Yes, sir. Sir,
Okay.
these are low
Why?
on all the
Because it is,
sequences.
yeah, dark in all sequences. So I told
Yes, sir.
myself, I will not give an answer before I see the X-ray. What happened
Okay.
here, my colleague? Anyone have any information about this sequence? This is a stair, but why this is very dark stair? I will tell you.
Uh,
We have
okay.
many types of fat cell. Mild, moderate, marked fat cell. This is markedly fat cell. I don't know
Mm-hmm.
why they did like this, because almost we lose most of its significance. But it may be needed in some cases, especially if you want to examine the bone marrow well for any lesions, for edema like this. But this is the market type of fat cell. When we did this X-ray, it is very clear.
Yes, sir.
So
Yes.
you must ask. The examiner will not give you without asking. It is very clear here.
Okay.
The
Yes, sir. Yes, sir.
osteoichiliosis surrounding the joint in the
Yes, sir.
epiphysis like this. Okay?
Okay.
Thank
Yes,
you
sir.
so
Yes.
much.
Thank you. Thank you so much, sir. Allah
Welcome.
Hafiz.
Welcome. Next candidate.
Yes, sir.
Welcome, doctor. This
Yes,
is
sir. Thank you, sir.
20-year-old male patient with pain in the forearm.
I've requested remote control, sir.
Doctor, your voice is a bit
Am I
not
audible?
good. Yeah, but I think there are some noises. No.
Hello?
Yes. Go on.
Yeah. So shall I scroll, sir? I have requested for remote control.
Yeah, go on, go on.
Okay. So I'm provided with an axial T2 weighted MRI image of a patient. I'll just take a minute to scroll through the images. Sir, it's
Hello?
not scrolling. I request you to please
I
scroll for me.
okay, I will just go. Leave the mouse.
Yes,
Go
sir.
on.
So there is, this is a axial T2 weighted image. I'm seeing that there is high signal intensity surrounding the um, radius along the
Yes,
extensor aspect.
yes,
The muscle also appears bulky. So can I have a look at the coronal images?
this is a coronal.
Okay, so I'm provided with the coronal images of this patient where I'm able to appreciate that there is a break in the cortex of the bone, most likely the ulna. This is the right shaft of the ulna with surrounding edema. So it appears like there is some minimal, no, there is no obvious displacement of the fracture fragment, but there is a discontinuity in the bone.
Yes.
Yeah, so I see, Does the patient have any history of trauma, sir?
Just swelling.
Okay,
By the
okay.
way,
So,
thank you for your question. And some examiner يعني give a very short brief answer, like I did, really, just a swelling. Or no, like this. Don't hope he will give you a more and more clinical data. He will give, sure, but not too much. Go
okay,
on.
okay. So I would want to rule out if the patient is having any underlying primary neoplasm, sir, because this could be a traumatic fracture.
Okay.
Sorry, a pathological fracture if there is no history of trauma. So I would want to correlate with the prior images and to ring up the referring physician and check with him if the patient has any known primary malignancy.
Okay. What do you, other than that, what do you want to do else?
I would want to correlate with any X-ray if available, sir.
What else?
Or if any CT also.
You think we have city here? One.
Okay, so I'm provided with CT of the same patient where I'm able to see that there is diffuse sclerosis and thickening involving the visualized extent of the ulna. There is a intramedullary nail, there is an external nail which is seen piercing through the cortex and entering into the medullary cavity. And the periosteum is thickened at this level and it is sclerotic. Here I'm able to see that there is some, it looks like a permeative kind of a periosteal reaction.
Okay.
So I would think of one differential as probably the patient could be having an Ewing sarcoma.
Okay.
So yeah, also there's no obvious soft tissue swelling. Yeah, there is a obvious soft tissue swelling. Also, I'm seeing some air foci which are seen in the soft tissue anterior to the visualized extent of the ulna. This could represent any prior history of intervention, if any, or probably there is some infection going on.
Okay. Look here. Which sequence, if you revise again the MRI, wanted to revise it?
Can I have a look at the stir coronal, sir, if available?
Okay, stir, no stir. What else?
Okay.
There are T2. This is fat set.
So I would want to see for any breach in the cortex. So here I'm able to appreciate that there is a breach in the cortex and this is extending anteriorly to the soft tissue. So this could represent a sequestrum or a dead bone, and this is likely a cloaca which is communicating between the medullary cavity and the external
Your
soft
final
tissue.
diagnosis?
So this is a osteomyelitis with
Are you sure?
sinus.
Are you sure?
Yes, sir, because I'm able to see that there is a definite sinus tract which is causing a breach in the cortex and extending to the soft tissue externally. And there is an underlying fracture as well, as I had seen previously.
Okay.
There is some surrounding edema as well in the bone and
Okay.
also in the soft tissue.
Have another look here. Where could you think this is Ewing or osteomyelitis? Look,
Sir, sorry?
Ewing sarcoma or osteomyelitis?
Now I think it is an osteomyelitis because I'm able to see some air foci within the soft tissue, which represents that it is an infection, most likely. However, I'm not seeing an external communication to this. Yeah,
What
there
is
is a. This is probably the sequestrum, sir, which is extending.
no. What is this? What is this? What is the name of this procedure?
Is it an? I'm not sure, sir.
Biopsy. Biopsy.
Okay, biopsy.
Oh,
Okay. So, okay, then in that case, I think it is most likely an Ewing sarcoma.
thank you so much, doctor. It was an case of Ewing sarcoma. If you give
Thank you.
the post the both differential diagnosis, it may be acceptable. But after I show you the X-ray, the CT, look here, my colleague, look here. This is, especially in the MRI, this is soft tissue mass here in MRI in T2. Look,
Yes,
look
yes.
here. It looks like soft tissue. Somebody may told me, doctor, it may be edema. Okay, but look here. It is very localized here. At least tell the examiner I'm worried more about Ewing sarcoma. I need post contrast to see or delineate or highlight the soft tissue component. Or okay, or
Okay, sir.
my first is Ewing, second is osteomyelitis, but really it is looks like why? Because look here, the mass, the edema didn't respect these lines, either fascia or fat planes, didn't respect what the mass stopped here. And look this to this convexity, the mass displaces the muscle anteriorly and causing convexity here. So it is Ewing sarcoma. Okay, my
Yes,
colleague, look here,
yes.
look,
Thank
look, what is this? Okay.
Yes.
So if you are in a doubt, tell the examiner the most suspected diagnosis and give him another one, the second one. Okay?
Yes.
Uh, what is this? Okay. Dr. Anam, still we have another candidate or not? I think we finished.
Our list is finished right now.
We finished 8 cases?
We finish 7 cases.
7. Okay.